Well, greetings from Wisconsin, and yes, it did snow there yesterday. I'm talking about the inspector's viewpoint on cone beam CT. I am the chairperson for H44 Task Force, which is a works in progress, and I'll explain that at the end of my talk. Anybody have last talk syndrome going on yet? We're near the end of the day, but it's almost over. You'll make it. I have to credit my best friend Amy for the photographs from the zoo that you'll see. Milwaukee County Zoo is fabulous. So what are we going to consider? Cone beam CT's history and evolution. Who's recommending what, which you've kind of heard a lot of already. Manufacturer QA/QC. What some states are saying, which is something you haven't heard. And where do we go from here? History of cone beam CT, best place to look for any history of anything is Wikipedia. And it was first introduced in Europe in 1996 with a new TOM 9000. And it came into the US market in 2001. October 25th, 2013, during the Festival della Scienza in Italy, it was introduced there. And they received an award for cone beam CT invention and revolutionary invention that changed the world's dental radiography panorama. Back in 1996, that's what you were getting. Now, this is what they're getting. This is a typical cone beam dental CT unit that I'm sure a lot of inspectors have already seen. But as we've come to discover, cone beam CT is becoming a lot more than just dental. You'll see cone beam CT in ENT offices. You will be eventually seeing them in orthopedic offices. There are also add-on units with medical C-arms and interventional radiography, and add-ons to radiation oncology linear accelerators. This is the newest medical ENT one I've seen out there. And this is the medical orthopedic one that I alluded to. It's the only one that is currently being used in the United States. And the company that manufactures it just in March did apply for 510(k) status. So they will be out in the not too distant future, I'm sure. This is a typical C-arm or interventional radiography unit. Again, it's an add-on unit, which is a fusion unit. So one thing you have to consider is the primary intended use of this unit is the C-arm. So the cone beam CT portion is just an add-on unit. So how do you register it? How do you test it? How do you make sure all the compliance stuff is done on it? Is it just like mammography with 2D, 3D? Is it two different units then? So there's a lot to consider in the future. And again, this is a medical radiation oncology unit, also with the add-on of cone beam CT. Who's recommending what? A lot of this you've already heard, but I'll go through it in my much condensed version. FDA, ADA, SSR, AAPM, NCRP, IAC, they all have recommendations for cone beam CT specific. FDA, I guess the best way to put it, in the FDA's initiative to reduce unnecessary radiation exposure for medical imaging, the FDA recommends imaging professionals follow the principles of justification and optimization in the protection of patients undergoing any radiographic examination. And I think this statement follows through with all of the other groups that we're going to talk about yet today. American Dental Association, breaking it down into topics and recommendations. You have patient selection, thorough review of patient's history, imaging history, clinical exam. Does this patient need a cone beam CT? limiting dose, optimizing the image quality using the smallest field of view. Qualified medical physicist for shielding plan, initial and annual evaluation. Quality control, following the manufacturer's QC or guidelines established by the qualified expert. SSR Part F also has a cone beam CT section in it. Talks about making sure your beam alignment is within 2% of your SID. Center of your X-ray field aligned within 2% of the SID. Qualified medical physicist evaluation within 30 days of initial installation and at intervals not to exceed 12 months, and within 30 days of a change or replacement of component that affects radiation output or image quality. They further go on to say the QC they have to have a QC program, follow manufacturer's guidelines or those established by a qualified medical physicist. Operators must have available QC instructions, including the use of the cone beam CT Phantom, QC schedule, and the most recent QC records. I'm just going to read this, the exemption. The qualified medical physicist performance evaluation on cone beam CT systems capable of operating at no greater than 100 kVp or 20 MA shall be performed at intervals not to exceed 24 months or at an interval approved by the agency. AAPM, the TG 261 is currently drafting a position on QC for low-dose dental and maxillofacial cone beam CT systems. Works in progress. NCRP report is also still in its draft form from my last communication with our contact person. And they are following manufacturer-specific instructions for QC. Patient selection should be considered a component exam, a complementary exam with the proper patient justification considerations. Shielding requirements. Consideration should be made based on machine location, machine settings, imaging geometry, and patient's positioning and workload. Operator trainings, initial and continuing educational requirements are included. I.A.C, Qualified Medical Physicist Evaluation, initial and annually, and I did look it up. Annually is not defined, so I went up to my room and grabbed that, or whenever components change is warranted. QC, quarterly review of tests, standards, thresholds, timelines, and results. Patient dose tracking, they request that you measure patient dose and it be recorded. Technical quality assessment, a program that evaluates the ongoing clinical image quality and radiation dose information. This program will include thresholds and corrective action requirements. They further go on to require staff qualifications for specific to a medical director or dentist, same with the dental or medical staff, technical staff, and the qualified medical physicist. Staff training, documentation of initial training, and staff continuing education that's required, 15 continuing education credits every 3 years, and a QI committee to review a standard of measurement of the technical and interpretive components. Manufacturer QA and QC. This is where it gets complicated. And we have gotten, my task force in particular has gotten almost inundated because there's nearly 25 different just dental CT units on the market today, and they all have different QC programs. And another consideration is dental and medical cone beam CT QC compliance should be held to equal standards. As a tech, I say yes. But when you get into a dental office and try and get their information, it's like pulling teeth. Sorry, really wasn't going to say that. I know. QC test requirements vary by manufacturer, phantoms done by facility or outside service. This is where in Wisconsin we've discovered a real sticky wicket. I have been told that cone beam CT falls under CT and its guidelines for providing a phantom to the facility. In Wisconsin, I want to say 9 times out of 10, there's no phantom. They've been told that there's a place that they can go to that's going to come in and do all their testing for them once a year for a fee, so they don't need the phantom. So I'm still trying to get as much information as I can for our task force as to what other states are finding. So if anybody has anything to add to this, please take my email address at the end of this and let us know what your states are seeing, what you're finding, what your thoughts are. And we're just trying to get to the bottom of this, because most of the places I've gone that have had this company come in and say, hey, I'm going to do your QC for you, well, where are the records? I don't, what records? What are you talking about? They don't have anything to show me. But I can't cite them because Wisconsin doesn't have anything in their code yet about cone beam CT. All I can do is let them know they need to get that information for our next inspection. So again, it's phantom done by facility or outside service. Where do we go for that? And that leads me to asking for QA/QC records in a dental office. What you talking about? And yes, that's my grandson. One thing that hasn't been touched on today is what some states are actually saying about or have in their actual regulations for cone beam CT. We're fortunate to have some committee members from all of these states, so we have that information readily available. If there's states in the audience that do have information for us, again, I would love to hear from you. But right now, this is all we have. So New York State Code 175 requires written QA program, QC manual, radiation safety policy, and procedure manual. QC must follow manufacturer's guidelines and utilize the manufacturer's phantom. Quarterly and annual tests, including QMP tests to review patient dose measurements. New Jersey, ensure that the dental cone beam CT unit complies with all current regulations. Ensure that all applicable tests are performed at required frequencies. Ensure that a qualified medical physicist performs an initial and annual QC survey. Microphone. I don't want to get yelled at.
While I was doing some research on cone beam, New Jersey recently did something where they actually put it in the code itself, their requirements, and they actually have a fairly codified list of the QC testing that they're requiring. So I don't know if anybody here's from New Jersey.
I actually have that whole list, but then, yeah.
Okay.
But yeah, no, it is very, very detailed. So thank you. Ensure that only appropriate credentialed and properly trained staff perform QC testing. Ensure that all cone beam CT procedures performed on patients follow the established scan protocols as evaluated by the qualified medical physicist. This leads me to another point that Lisa shared with me, and we've been working on too. As I go out to do inspections, or as you go out to do inspections, when you run across a cone beam CT unit that is actually newly installed, when they had their applications done, did they willy-nilly do Joe Blow dental assistant to do a test on? That happens. So you need to be aware that during applications, there may be a patient or two done that isn't really a patient or two. So ask, when you had your installation done, who did you actually do imaging on while that happened? Ohio. They require them to develop and implement a written QC program. This program must include an initial installation and annual test by a radiation expert. Annual test must include assessment of radiation dose and an evaluation of imaging quality. QC records must be available for inspections. Can't find that in Wisconsin all the time. Pennsylvania, this is still proposed. I meant to add that to the slide, but it was in my beginning. Evaluation of beam alignment annually by the qualified medical physicist. Performance evaluation to follow nationally recognized tolerances initially and annually not to exceed 14 months. Follow manufacturer's QC recommendations or those established by the qualified medical physicist or the department. So where do we go from here? I'm sorry, my talk is shorter than I thought it was. CRCPD H44 Task Force, which I am the chair of, and I have one fabulous member here in the room with me. Thank you, Becky. We have been charged to develop and publish a white paper that would be helpful to radiation regulatory programs on diagnostic X-ray cone beam CT used in dental and medical facilities that describes the general principles on how the unit works, quality control tests, and shielding requirements. Develop a protocol for state radiation control staff to use during inspections of cone beam CT units, and provide a written guidance on operator certifications for cone beam CT units. Right now, we are it's a works in progress. We have a good chunk of it together, but we are waiting for the final NCRP report and AAPM TG 261 proposal so that our recommendations are consistent with theirs. We absolutely do not want to go against who we deem are qualified experts in this field. And we are going to be creating, or we have actually started creating a checklist that is similar to the CT checklist developed by CRCPD's H32 committee, as Lisa alluded to in her talk. And inspector in training. So, and there's my contact information. If anybody has any questions. Yes, Lisa? Lisa's coming. Okay. Oh,
Do you have or any restrictions on in any of the states that you, in other words, what's your recommendation? We find that the dental units may not be the problem. What we're finding are the ENT guys that are installing these that have no training at all, but they've got a bargain used machine, and they basically want their medical assistant to run it. And I'm just asking, where from CRCPD's perspective are you recommending requirements for training or for both the owners, the operators, in other words, the physicians, the operators? I'm very antsy when I was the physicist out there testing this thing, because no one had a clue.
right.
Absolutely no clue.
I have only inspected one ENT unit. It is run by the physician himself, and it is IAC accredited, and their paperwork was immaculate. So from a state of Wisconsin standpoint, any ENT unit has to either be run by the physician himself or a registered and licensed RT, because it's a medical unit in a medical facility. I'm seeing just the opposite with these dental ones that are being run by dental assistants that don't know what the field of view means. So, or they're still using film screen settings on their intraorals when they've gone digital 3 years ago. Yes, sir.
Hello. Just a quick question regarding Wisconsin. Sorry. Am I on? Okay. So on? With the state of Wisconsin, the new devices that you were saying that were coming out onto the market, does your state just go by what the FDA approves, or do you put other stipulations on new devices?
Right now in Wisconsin, as far as cone beam CT, we're waiting for our paper to get written. So I don't know if that's an answer to your question, but yeah.
Okay,
Um,
thank you.
Uh-huh. Come on up, Lisa.
Of course, I could have asked you these last night, but they didn't occur to me last night when we were working on our stuff. So Tyler mentioned earlier about the cone beam CTs being driven towards the accreditation with the IAC. Do we have an understanding why is that being tied to any reimbursement issues that we're aware of? It is to the reimbursement? Okay.
Yeah.
That's interesting because I had not heard of that, but we don't, of course, don't have as many at the ENT type offices as we do at the dental.
Yeah, like I said, this ENT office was, it was like a pleasure.
Yeah, which is nice.
Yeah.
So, and then I was just going to make a comment that we have a couple of enforcement issues that we've dealt with in Texas with some major vendors of this kind of unit and maybe some other big panoramic type equipment that's seen in the dental offices where they were doing, x-ray in the dental assistant or and sometimes themselves. And so we've actually had a couple of successful cases where some of the major vendors have actually put together some type of a document that they send to the facilities in advance that clearly states to do your applications training, you must have actual patients there with a prescription order to do these tests. We will not continue that part of your applications training until you can show us this document. And they give us a copy to the facility for inspection purposes, and they retain a copy for their purposes. So
Fabulous.
we're hoping to move them in the right direction.
Yeah, I have been, since we had the discussion probably 6 months ago, I've been asking, and I have not run across that
Good.
yet, but I can see where that would happen.
Yeah. Well, the excuse we got in enforcement was, it's not our fault they didn't have any patients there that day. Yeah, it kind of is. You kind of drove the applications training, so.
Any other questions? Oh, there's a line. Woo. I'm getting intimidated.
Just a couple of quick comments. Please hurry with the white paper, and if you need double APM to hurry, tell them so.
Okay.
Mainly because we're seeing with the dental right now, the same comments that we heard when they went to digital. They're hearing from their application specialists or from their salespeople, you're not using radiation anymore, so go for it.
Yeah.
And we're hearing that
Yeah.
a lot.
Yep, thank you. Becky, you got that, right? We're being put to task.
Hi, Laura.
Hi.
So, other than issuing NOVs, notice of violation, what other legal enforcement action can you inflict on your registrants?
I don't want to say that we are,
By law, that you're able to exercise.
as far as the phantom goes, I could fall back on the fact that our CT regs do have phantom requirements in them. So yes, we could cite them, but
Other than citation, do you have the legal authority to shut down the practice? so
Oh,
to
yeah.
speak? You do?
yeah,
Oh, okay.
yeah.
Because in New Hampshire, we don't have that authority.
Yeah,
That's a
we
problem for
actually,
us.
we have a dentist right now who's being shut down by the state because he actually refused to allow our inspectors to even come into his office.
Right.
And he hasn't paid his fees to licensing fees, so yeah, he's getting, yeah.
All right.
Yep.
Thank you.
Nobody else got this many questions?
Not really questions, just you asked for information. So in California, we do hold the cone beams as medical devices.
Even
other
in a
than the ones
dental office?
Other than the ones in the dental
Okay.
office. So they do have to have an RT who's been certified and supervised by a certified physician. So in the dental office, they have to work for a licensed dentist, and in either case, they have to document training.
Okay.
But we don't have specifics on what that training is.
Yeah, in California, you have a lot of dental x-ray labs too, though. Aren't those pretty much run?
We don't have a lot of labs.
Yeah.
If it is classified as a dental lab, they do have to have a certified tech.
Okay, because we had one in Wisconsin, and I managed that for a while, so that's the only reason I know about that.